invitation. It's an honor to come here and be among friends. A bit about some of the work we've been doing with the endovascular management of hydrocephalus. These are my disclosures. I'm co-founder of Ceravasc, which makes the eShunt, and I also consult for Cirrus. So hydrocephalus is buildup of fluid in the brain, and usually it results in dilated ventricles. As you can see in this patient that has dilated frontal horns, temporal horns, third ventricle, as well as evidence of transependymal flow as the CSF is literally going through the ependymum. There are two types: communicating hydrocephalus, which is the most common, and obstructive hydrocephalus. They can be differentiated usually with obstructive hydrocephalus resulting from a narrowing or an occlusion of the aqueduct of Sylvius, which connects the third and fourth ventricles. The current standard of care involves using a surgical VP shunt or ventriculoperitoneal shunt. It's a procedure which involves placement of a catheter into the ventricle through the brain, drilling a burr hole, then under the scalp, passing the tubing. There's usually a valve that enables us to control the amount of pressure at which the flow begins. There's also usually an anti-siphon device here, because when the patient stands up, there's a tendency for the fluid to actually start flowing in the siphon mechanism. And there's an incision in the abdomen where you have to reach the peritoneum to put the distal tubing. So the entire side of the patient is prepped, and usually 3 incisions. This is what you get after the procedure. You check for placement of ventricular catheter. The catheter goes across the chest and then into the peritoneum. Now, there is no relationship between the pressure in the brain and the pressure in the peritoneal cavity. And so a number of complications can occur. One of them, as you can see here, is the presence of subdural fluid collections as a result of overdrainage, usually related either to a low pressure in the valve setting or to a siphon effect where the patient stands up and they get overdrainage. The other problem is, of course, although this is one of the simplest procedures that we train on, and now with stereotactic guidance, it's possible to get good, accurate targeting, but nonetheless, you still have malpositioned catheters, which can go through and affect eloquent portions of the brain. And of course, there's a complication with patients that are on some anticoagulant or antiplatelet medication, and sometimes even when they're on neither, when you can get a hemorrhage as a result of passing through the brain parenchyma itself. You have other challenges related to VP shunting. One is overdrainage, and you can have collapsed ventricles in patients with idiopathic intracranial hypertension, for instance, and having to replace this catheter, let's say if there's an infection, becomes a daunting task to actually find that track and aim for that single spot. And of course, just the overall increase in BMI across the world, you have a tendency to have more complications with distal shunt malposition. VP shunt failures have been well documented, and they can be up to 40% within the first 2 years, and can be quite frustrating both for patients and clinician alike. We all have patients that have had shunts for over 20 years without any complications, but also a number of them that have required multiple revisions. And so, as you have heard from the multiple other talks from my colleagues, aneurysm treatment has really been revolutionized. It went from open microsurgical clipping, which we all really enjoy technically, to much more advanced, combined techniques with stents, coils, fluid diverters. And one of the things that got us interested, me and my colleague, Carl Hellman, was he was always amusing and upset that we were stealing all the good cases, and he'd still have to come in the middle of the night to do a shunt revision. And so we got, started talking about close to 12 years ago now, about how can we come up with an endovascular solution to take away those painful cases, kind of treat hydrocephalus in a novel way. And as you know, the CSF is actually absorbed by these structures near the venous sinuses called arachnoid granulations, which act as passive filters of the CSF back into the venous system. And so the idea was, can we come up with a biomimetic device that can replicate these arachnoid granulations? Looking at different sites where the CSF adjacent to the venous system, the one that we thought was the one that would enable us the safest and simplest approach without compromising the existing venous system. For instance, if we were to use a transverse sinus, then that could put it at risk for thrombosing or clotting or injury. And so we decided to choose the inferior petrosal sinus, which is a highway that we use for many endovascular treatments, such as carotid cavernous fistulas, which are treated usually by a transvenous approach through the inferior petrosal sinus. And so through the help of many over the last 8 years, we founded this company Ceravasc that makes this e-shunt system, effectively a biomimetic device that tries to reproduce the function of the arachnoid granulation. This is the actual device itself. It has a malacot, which will sit inside the CSF cistern, and it will actually drain into the jugular vein. It has a slit valve, which prevents backflow. If the patient coughs or bears down, we know that the ICP shoots up transiently. It's usually followed by a CSF pressure going up as well. So it's a transient phenomenon, but nonetheless, that prevents blood reflux into the system. And so the inferior petrosal sinus is very familiar to the interventional endovascular trained operator. It is a vein that's encased in the bone and effectively is encircled by bone on 270 degrees, if you will, but on this side it has dura, and it basically separates, this dura separates the inferior petrosal sinus vein from the CSF cistern. And so the goal would be to place this device across this dura. So to do that, we devised a two-step system, which involves using off-the-shelf standard catheters. Here is a 6-French guide catheter that you use in the internal jugular vein. It's a transfemoral approach, can potentially be also done from the arm or even the internal jugular itself. And then you use a microcatheter to select the cavernous sinus, where you deploy a small anchor, and the anchor will provide a highway to use a rapid exchange system for delivery. This is what the anchor looks like, and what's special about it is it has a flat trail, which enables a very low profile for the system. And the second part of the system is this delivery catheter, which has a needle on it, which is protected by a guard that effectively enables us to navigate it into position and then retract the guard when at the target position, gently enabling us to advance through the dura into the CP angle cistern to deliver the e-shunt. The e-shunt itself is preloaded inside the needle. So again, this is the flat trail that you see. This is the needle guard that protects it. There's 2 wires that enable us to retract the needle guard. And as you can see, the flat trail enables a much lower profile for the system. If it was a round wire, it would make the whole system larger. And so the system is about 4 French, 4.2 French in size. Another safety feature is the fact that the flat trail exits at a certain set location, so that when you are advancing, if an operator is inattentive or ham-handed, they will not be able to penetrate beyond a certain depth, thereby protecting the nervous structures. The e-shunt itself is held in place by this micro stent called a shroud, and enable you to kind of really control it under the final release. And this is what it looks like live. It's a very small device. It's an 0165 lumen, and you'd think that's very small, but actually because of the short distance and the small size, there's very little resistance to the flow. This is seeing the valve in action. You have a high pressure in the CSF, which you see here in blue. We did experiments in a sheep model to assess the safety of going through the vein into the CSF cistern. Now, the CSF pressure is usually higher than the vein, so this is a lucky condition for us, because we were able to penetrate through the torcula into the cerebellar cistern and actually get a CAT scan showing no blood on multiple animals. And this is the CSF from the cistern through a tubing of similar size. So then how do we deliver this device now that we have it? using an endovascular approach. To do this, we analyzed a number of MRI that we had from patients undergoing gamma knife or trigeminal neuralgia in multiple decades and characterized using 3D software, the cistern and the inferior petrosal sinus itself that you see right here. This is a jugular vein and the jugular bulb going to the inferior petrosal sinus and up to the cavernous sinus. And basically, we plan to deploy the system by going across at this site. So we published this data with this full characterization of the anatomy and then moved on to trying this delivery system in cadaveric specimens using the actual angio suite with a Lexel frame to immobilize the skull. And this is the target of exit. We found this technique called 3D road mapping that is available in most of our angiography suite and we rarely use, very useful. And what effectively it does is it enables you to select the spot in 3D space on the model and then send it over to the fluorography machine so that when you move your C-arm anyway, the point will be there in space. And as you magnify your image, that point will be constantly available as a reference to guide you in your device placement. So this is a quick video showing how you get a 3D rotational angiogram with a microcatheter in the cavernous sinus. You select the site of entry. You basically cut out, this is on the Siemens machine, but same thing on Philips. And when you have that, you send it to the machine. This is your exit site and the IPS. Then you can see here we're advancing the anchor. Excuse me. Sorry about that, we're advancing the anchor here. And as the anchor is deployed, that provides for the flat trail. And then we then work in the projection to be orthogonal to the exit site. Here's the delivery catheter. We're unsheathing the needle. And then as you pull out the needle, then you can advance the needle, go through the dura into the CP angle cistern, and then deploy the E-shunt. You can see the malachite flowering, and then you can tug it back against the dura. And so now the malachite is actually in the cistern. Then you go back and recover the anchor, which is just a temporary device. This is what it looks like in the cadaver at the site. This is a jugular tubercle. It's halfway point in jugular tubercle, and that's basically the exit site of the device. Again, showing the 3D road mapping, unsheathing of the needle, and then deployment of the device. So what if the device gets infected? What if the patient has an infection of the CSF or meningitis? Well, it's possible to retrieve it. This is a snare. You can actually grab the device and pull it gently back. It'll collapse the malachite through the dura, and dura will self-seal. So our strategy was basically first to start a first-in-human study, and then hopefully lead to a pilot studies in the US, and eventually to a pivotal trial. Right now, I'm going to show you some data from the first-in-human that was done with our colleague, Dr. Lilik in Buenos Aires, and also the first case of one of our pilot studies here in the US. So we set out to connect with Dr. Lilik. We had him come and visit Boston and do some training. He has a very unique background, having trained neurosurgery, also in pediatrics. We also trained at kind of close sister institutions. He trained at UCLA, I trained at UCSF, so it was always a little bit of competition, but we're always very friendly. And so we went down to Argentina and set up the trial, and this is the first-in-human results. In order to first determine whether this would work, we thought the best patient population would be patients with subarachnoid hemorrhage that already have an external ventricular drain, so we could actually measure their pressure and document that this device is actually working. And so those are patients that basically have subarachnoid hemorrhage, came in requiring a drain, and then after about 7 days, when they got an EVD clamp test, could not be weaned and had a spike in their ICP, suggesting they would go on to require a actual VP shunt. And so those patients were included. And then obviously there were anatomical considerations that will go in this study. So this is the first patient presented with a subarachnoid hemorrhage from a ruptured MCA aneurysm, which was coiled by Dr. Lilik's team. And then on subsequent testing, this is the clamp test of the EVD. You can see that the ICP spiked and the patient did not tolerate an EVD wean. And so she was enrolled. The anatomical imaging, we use a T1 weighted gadolinium study that shows you the depth of the cistern, as well as the path of the IPS that you can follow here and its diameter. We also do segmentation where we separate the IPS that you see in purple here, and in red, any arteries. Usually it's a branch of ICA, possibly PICA, or sometimes even the vertebral artery can swing by close to the site. And that will help you decide whether you choose one side versus the other, or whether the patient is not a candidate. This is the actual procedure for the human case. Dr. Lilik performing already has the anchor in position, and he's actually pulling back. And you're going to see the needle guard come back. And then as the system is pulled back, you see it will straighten. This is what we call the straight shot approach. And that really leverages the whole fact that the IPS makes a curve. And that's what enabled us to then use a straight shot approach across the dura into the cistern. So the needle is exposed at this point. And now you see as Dr. Lilik pulls back the system, it aligns. And now we can advance and it crosses the dura.
Well, Evie's with her, so I think that she's gonna be all right. When we were at summer camp,
performed the run to show that even though the needles across the dura, there's actually no counter-slippage into the cistern or CSF. And at this point, the E shunt was advanced, and then you can see it as the malachite opens and flowers, it will tend to plop down, and this is a sure sign that you're not in the IPS. And at this point, it involves stabilizing the malachite with the shroud and pulling the shroud back until it's released. And then the anchor is then removed. So what happened to the patient? Because we had the EVD in place, we're able to measure the ICP. So this is the ICP that decreased after the placement of the E-shunt. And this is really the first time, many firsts. One is the first time that you're able to access the central nervous system percutaneously through a catheter system. And the first time that this concept of placing a miniature shunt enables you to actually decrease the ICP. This is the malachite can be imaged or the regular CAT scan, and this is a cone beam CT showing the path of the body of the E-shunt into the IJ. And so the ICP stayed down, and then you can see some variation as the patient was turned and so on, and eventually was removed at day 36. These 4 more cases showed the similar pattern of decrease in ICP, and so all the primary endpoint was met, which is the ability to remove the EVD at 36 hours. What I want to talk to you today is something that really involves a very large part of the population, which is normal pressure hydrocephalus. It involves the elderly. It's probably thought to involve up to 700,000 patients in the US. It's one of the major causes of dementia, and it's a big social cost, in terms of both families that, place their loved ones in nursing homes, as well as, the need to kind of take care of patients that are debilitated by this. It is effectively characterized by impaired gait, cognitive dysfunction, and urinary incontinence. This is the classic triad, mostly is impaired gait as the first one. This is a very nice case study that was published in New England Journal, a group from Harvard that shows a typical appearance of normal pressure hydrocephalus with computation of the Evans ratio, the beaking of the ventricles. And this is a picture of the patient before a shunt was placed. This is just a conventional VP shunt. And you can see how she's got very shuffling gait, where, it's kind of hunched over and really debilitated. This is after her shunt was placed, I believe around a week. You can see that she's already walking more upright. She's more spontaneous. And the next video is extended follow-up. You can see a completely different person who's independent, and actually is able to walk very fast. And so one of the assessments for this and the response is something called the time up and go test or tug test, where you actually check the gait and how it's affected by shunting. A lot of patients undergo a test procedure where they have a high volume lumbar tap and then their gait is tested. And if the gait improves, there's a high probability that would benefit from a shunt. Unfortunately, in this population, VP shunt can have a high risk. A lot of these patients are over 7 years old and are frail, and then the 3 incision and the anesthesia and the discomfort can sometimes throw them for a loop. So when you look at the number of patients that you help with, this is one that may develop complication from the procedure. Not all neurosurgeons offer this as aggressively as they probably should. So we thought that a minimally invasive approach may help. This is a patient in Buenos Aires, the first patient that had the part of the MPH trial. Again, you can see the IPS was kind of adequate size, and the cistern was appropriate. And this is actually the system being deployed. You can actually see the access across the dura. You can see the malakoff here coming out of the delivery system, and this is the final result. This is actually a 30-day follow-up. You ask, how can you check for the patency of the device? One possibility is by using gadolinium cisternography, and you can actually trace that, and you can see this accumulation of gadolinium in the jugular bulb after the CSF is actually injected with gadolinium on the side of the E-shunt, but not on the contralateral side, consistent with the E-shunt patency. So at the 30 days and 90 days, there was improvement in the patient gait, the urinary incontinence, and the cognitive impairment. All were improved. This is on the left is the walk gait pre-treatment. You can see the gait is a little hesitant, careful. And on the right is at 90-day. A little more self-assured. So the 30-day results in the first 3 patients all show improvement, both in the top time up and go gait test by about 28%, improvement in the MoCA or the cognitive ability, as well as improvement in the bladder symptoms as well. And this is the 90-day test for one of the patients, which continues to show improvement in gait and cognitive impairment and urinary incontinence. Now, there are obviously anatomical considerations sometimes. This is an interesting patient we sought to enroll. And then actually, if you look at the segmentation here, we also segmented the bone. You'll see that although you can see the inferior petrosal sinus, this is one of those anatomical variants where the IPS is actually encased in bone and actually has no connection with the dura. And you can actually see that on the MRI as well. So anatomical screening is very important. This is a rare finding, but it just tells you that just like when you're treating a 2-millimeter aneurysm, you need to know what the anatomy looks like ahead of time as you're embarking on the endovascular procedure. I think I've already mentioned some of these results, but the point is, how do we compare surgery to an endovascular solution? Of course, we're extremely early. These are all preliminary studies, but usually the length of stay for the E-shunt has been, most of these patients could have been discharged the same day of the procedure. These were all done under general anesthesia, but were kept in for about a median time of 1.7 days. We have not had a procedural complication at this point. We recently started a IDE study for NPH in the United States, and this is our first patient that we just treated at Yale. This is the CAT scan and the MRI, and you can see the inferior petrosal sinus. This is the segmentation showing the loop of ICA and its relationship to our exit site. You can see we have more than 6 millimeters along the vector, which is what we need for safety. And we also look at the segmentation of the bone to make sure there's a good bony channel without overhang that would interfere with the advancement of the device. This is, again, in New Haven. You can see the anchor, and this is the system after we access the cistern, and this is the device being placed. So in conclusion, percutaneous endovascular transluminal access to the central nervous system has really been shown to be feasible and reproducible. Transvenous to cisternal access can be done safely with proper pre-op 3D imaging and careful planning. The proof of concept of using a shunt has been shown to result in decreased ICP. And the Ceravasc e-shunt is a minimally invasive approach that could potentially be a solution not only for communicating hydrocephalus, but for normal pressure hydrocephalus. And we're hoping to enroll, multi-centers and obviously have a much longer follow-up period so we can confirm the efficacy and safety. So thank you very much.
Thank you, Adele. I saw a question there on the chat. I'm gonna get the name of the person asking the question. The question was, is this only for adult population or also for pediatric?
Yeah, that's a great question. As you know, obviously, the system does have a certain size in it, and we are at this point centering on adults, possibly young adults, but really adult patients. Hopefully with time, we'll be able to miniaturize it as, technologies improve and imaging as well as, miniaturization. But at this point, it's for adults.
Thank you. Anything else, guys, for Professor Malik here?
No, just so I know you did a lot of the anatomical data is very helpful and allows us to have safety and planning the procedure and executing. Was any type of physiological impact? And I totally understand if you have, let's say, one inferior petrosal sinus that's ideal, is there a compromising flow on that sinus if this is the only way that drains? I mean, is there any other physiological information that is important to consider here, or it doesn't matter?
No, that's a great point. I mean, as you know, you and I both have coiled cavernous fistulas and shut down and coiled the entire IPS. And usually the patient has no complications. Luckily, we actually have follow-up MRIs, and we've found that there is no thrombosis of the IPS. So the IPS remains patent. The device has a heparin coating on it, and it actually goes through the IPS, but it's much smaller and ends in the jugular vein. But that's a great point.
Got another question from Zimbabwe. What is the rate of other shunt complications such as shunt infection?
For this device? Yeah, we have had one case of a patient who had a ventricular catheter for a long period of time and that had possible early low-grade infection that developed an infection. And so we were actually able to pull the e-shunt device with that snare technique that I showed, and the patient made a recovery. So, great, thank you very much.